You're listening to Medscape's In Discussion series on cancer survivorship, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Kathryn J. Ruddy. Dr. Ruddy is a professor of oncology at Mayo Clinic who provides medical oncology care to patients with breast cancer. In addition to her clinical activities, Dr. Ruddy co-leads the Mayo Clinic Comprehensive Cancer Center Cancer Prevention, Control, and Survivorship Program, and she is active in research focused on the prediction and prevention of toxicity in patients with cancer, as well as patient-reported outcomes during and after cancer treatment. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Hello, I'm Dr. Kathryn Ruddy. Welcome to Season 3 of the Medscape In Discussion Cancer Survivorship podcast series. Today we'll discuss young-onset cancer survivorship. First, let me introduce my esteemed guest, Dr. Narjust Florez. Dr. Florez is the Associate Director of the Cancer Care Equity Program, Co-Director of the Young Lung Cancer Program, and a thoracic medical oncologist at Dana-Farber Brigham Cancer Center. Dr. Florez's clinical interests include targeted therapy for lung cancer and the care of women and young individuals with lung cancer, including their cancer survivorship. Dr. Florez, welcome to the Medscape In Discussion Cancer Survivorship podcast.
Thank you. I'm very happy to be here. To our audience, Dr. Ronnie was one of my mentors when I was at Mayo Clinic, and there was around 6 months during my training that was considered breast cancer. So this feels like 4 cycle coming back and having this discussion with one of the individuals I learned on how to conduct survivorship research. So thank you.
Thank you, Dr. Florez. Some of you may remember that Dr. Florez was part of this podcast series in prior years, so we're thrilled to have her back again to participate in this Season 3. Dr. Florez, could we start by having you talk about the incidence of young-onset cancer and how young-onset cancers can present?
Thank you for that very important question. Since 2010, and even before that, we have seen an increased number of cases of young-onset cancer. And what is young-onset cancer? These are patients that are usually diagnosed before the age of 50 or the age of 45. These patients are diagnosed with cancer during a very disruptive time of their lives and often don't have any other person in their circle that may have been diagnosed with cancer. The number of cases are increasing. Colorectal cancer is one that we have seen the highest rise in number of cases, and that's what a large campaign is pursuing colorectal cancer screening to start at 45 instead of 50. So 45 is the new 50, and Dr. Kimi Eng has spearheaded a lot of these efforts. When I was at Mayo, we did Dr. Ruddy, in which we saw increased incidence of lung cancer in younger women. The young onset lung cancer is higher in younger women compared to colorectal, which can be seen in either sex. And young breast cancer is going up in certain groups and declining in certain groups. But the issue is this is the reality. Younger patients are getting cancer. Cancer should no longer be seen as a disease of older adults. So we have to open our eyes to this diagnosis because often these patients don't get a timely diagnosis because of the lack of association of these solid tumor cancers in your individuals. We often see testicular cancer and lymphoma in this subgroup, but now there's a new group of cancers that are affecting this population.
In addition to those diagnostic potentially delays, what are the unique challenges that your patients face during and after treatment when they are diagnosed at a young age?
So when we talk about young onset cancers, we have to see their challenges to the entire spectrum. So let's start with the first one, which is diagnostic delays. This is very unique to this population and to patients with colorectal and lung cancer, in which the symptoms cannot be fully specific. So we know that from our own study, young women with lung cancer are often told that there may be a mental health issue instead of lung cancer. So this data soon to be presented, the number one misdiagnosis was anxiety in this group of women, young women with lung cancer. We interviewed over 114 young women and identified that chest pressure was often attributed to anxiety when in fact was a tumor growing. For diagnosis in young individuals with colorectal cancer, often also mental health is included in these GI symptoms, and they're diagnosed with irritable bowel syndrome by symptoms without specific imaging, leading to delays on diagnosis. And a lot of these patients are unfortunately diagnosed with stage 4 when there are limited treatment options. And that brings a very important aspect that affects the entire survivorship, which is trust in the healthcare system. Many of them have sought care multiple times until the diagnosis, and many of them believe, which in fact could be supported by data, that they could have been diagnosed at early stage. So that affects survivorship, the trust, because since diagnosis, you were not here. Then after diagnosis, we know isolation is a big challenge in their survivorship. They don't have peers who have gone through this. They often have a parent or a grandparent that may have cancer treatment. So there is that lack of having that community. Luckily, social media has helped with some of that isolation, but my patients often report that they're the only person that is young in the entire waiting room, right? So they don't have anybody to lock eyes with. They don't have anybody to like, even in the hallway to say, man, this is difficult. So we did have created a lounge at Dana-Farber specific to or AYA or young adults with cancer. So they can have this little space in which they can connect. Even if it's not the same type of cancer, they have the same challenges with diagnosis. And one thing that we forget often to talk about it with young onset is the effects in family. With young onset patients are often the backbone of caring for others in the family nucleus. So younger women, younger men, and non-binary are often taking care of younger children, ages 4 to 18 or more. And they're also care for the older adults, their parents or grandparents. So in society, not only in the US, these group of patients are the caregivers. So who cares for the caregiver when the caregiver gets sick is an issue. And finally, these patients tend to have more aggressive treatments because they're able to tolerate it. But that comes with consequences, which is a large number of long-term side effects that affects all the spectrum, all aspects of their survivorship.
Can you talk a bit about fertility concern and fertility preservation? This is a topic near and dear to my heart because my own interest in fertility preservation during cancer therapy, which was inspired by a close friend's cancer diagnosis during medical school, actually was what led me to become an oncologist and to be passionate about cancer survivorship research. So I would love to hear you tell our audience a bit about how this plays a role.
And along those lines of the story is that we both have a similar mentor that also studies fertility. So we all have been passionate about this. And I think through my own personal experience with fertility, I have firsthand experience the challenge of it. So there's one main issue is that during training, medical oncologists, surgical oncologists, and radiation oncologists, we get very limited training about fertility and fertility preservation. You may get a lecture, 2 lectures, and if you're fortunate like me, my mentors do this. So you get extra training, but you have to go out of the way to learn. Most patients are not provided the opportunity of fertility preservation, regardless of the subtype of cancer. Breast cancer has been in the forefront and they have done more research and they have more options. Lung cancer is in the back burner behind still 1995. So the lack of training is a big issue. And the rush that is put for many of these young patients are very sick. We talk about delays in diagnosis. So they need to start treatment right away. But it's not our role as providers to decide fertility preservation for our patients. It is our duty to give them options. There are many options of fertility preservation. It can be easier for biological men with a sperm collection, but a sperm collection needs to take place. There are several samples that need to be collected. And for women, it tends to be a little more complicated. It can go from injections all the way to full stimulation and preservation. But the main thing is that we give the option to patients to make that decision and not make the decision for them. because we don't know what their cancer journey will bring. With the new advancements in therapies, I have patients with metastatic lung cancer living 12 years. So it is not my role to decide when and if they want to be parents or if they want to have additional children. It's not only about the ones that haven't had children, but also about the ones that may want more children. So I think having the discussion is the first step. And it is not expected of medical oncologists or community oncologists to know what to do, but to know who to refer the patient to. And we have nurses, nurse practitioners, specialists. Dr. Elizabeth Ginsburg is a great person that has done a lot of this research. But the main thing is to ask. I have a template in Epic because we're often so busy. We forget about so many things. But if you have it in your template, before you close that note, you need to click that you discuss or you will discuss so you can close that note. So that's a little tip that has helped me to remember.
That's a great tip. Yeah, I find the Epic templates to be so helpful for so many aspects of our care now. So thank you for that. Can you talk a little bit about your pregnancy and lung cancer registry that I think you did talk about a bit last year on the series, but we'd love to hear more.
So when we talked about pregnancy and lung cancer registry last time, we were not even live. It was an idea and a journey. So it all started with a phone call from one of my friends who's a OB attending and say, NJ, I need your help. And I was like, do you need help moving? Do you want me to see your cat? What is happening? And it was, I have a pregnant woman with lung cancer. And I still remember the feeling like today in which my belly just felt hollow. And he's like, well, you take care of your own patients. And I was like, yeah, but no pregnant. And that led to looking into the literature and realizing that there's no guidelines. That is, most of the data precedes targeted therapy. There is no data about immunotherapy. And all of these agents is what we're using mostly in these young patients. So as a result of that experience and having to get chemo for the first time in my career to a pregnant woman, and I remember texting my mentor, it's like, I can't sleep. She starts chemo tomorrow. And my mentor is like, yeah, I've done it like 100 times. We created the registry. And the registry is housed at the Dana-Farber, but it's an international registry. So anybody across the globe can enter cases. The cases are anonymous, and we ask for follow-up 6 months after the case has been entered and 12 months. And in a goal to get the most cases we can, also patients can enter their cases. And this is all full IRB approved. And it's because sometimes I don't remember the ADGAR of the offspring that may have been treated, but the mothers have the capacity to get such a detailed information. So for the registry, providers from all across the globe can enter cases. Nurses, nurse practitioners, physicians, families, and the patients can also enter the cases. And most importantly, we have 72 cases so far. So we have the largest cohort of pregnancy and lung cancer. And we learned that there's a significant lack of uniformity on treatment. We have cases from many countries across the globe, and we have seen lack of uniformity. And it's risky because a lot of these targeted therapies have not been approved, and they have not been studied for this population whatsoever. And immunotherapy, for example, all of it was studied in no sexually mature baboons. So that's data we have. So as a consequence of the registry, we have launched the Pregnancy and Lung Cancer Consortium with Dr. Bimbo in Switzerland and Dr. Marina Garasimo, in which people can bring cases to us or pregnancy, and we're happy to guide them because the literature is so diverse.
That's a phenomenal resource and design. I'm very excited to hear more about your results in the future. Another topic you talked about last year on the podcast was the importance of sexual health. Have there been any new data or interventions over the last year that you'd like to update the listeners on?
I think as we're talking about young onset cancer, sexual health takes a forefront. I think it's unfair to expect a 32-year-old woman diagnosed with colorectal or lung cancer or breast or lymphoma to remain celibate until the end of their days. Sexual health has many benefits, including help with self-esteem, with well-being. It can decrease even the amount of opiates that you may need. So sexual health is cancer care. That's the first thing I want to talk about. But Dr. Sharon Bober, as consequence of her studies and the SHARE study, which is our study in lung cancer, has launched the SHARE study, SHARE SHARE, which is sexual health after cancer treatment focused on younger patients. So this is for women aged 19 to 49, and it's based at Dana-Farber, but no medications are involved in the intervention. So the interventions focuses on cognitive behavior therapy, physical therapy, and it provides educational online sessions about body changes that these patients may experience during their cancer treatment and after the cancer treatment, and how to cope with that and see your new body, your new sexual health, activity, and intimacy. So this study is very interesting. Patients will be randomized to either group sessions or individual sessions. And it's called the SHARE study, which is sexual health and rehabilitation. And I think while we have documented the sexual dysfunction, this study is the next step, which is an intervention to improve sexual health in young patients with cancer. And the SHARE study is regardless of type of cancer. And if people are interested, they can just pretty much Google SHARE study with Dr. Bober, who's here at Dana-Farber. But I think the time for interventions is now when we talk about sexual health.
That sounds like an extremely important study. So, congratulations on taking that forward with Dr. Bober. Do you want to say anything about the potential for integrative approaches to be helpful for young patients specifically with regard to other areas of survivorship?
Yes. So I think early onset cancer care is multidisciplinary care because we have to look at these patients very long term, right? 1, 2, 3 decades after they have been diagnosed with cancer. And the plan is not to fix issues after we have caused them. The case is to address them before that. So a very important aspect is cardio oncology and their survivorship. I currently have 2 football players that went under treatment, like football players. So now they're going back to their strenuous activity. So I have to work with cardio oncology to make sure their heart is in shape to be running in a football field, right? I think other part of the multidisciplinary care that's very important is psycho-oncology for these patients. These patients that struggle with significant mental health. And as a millennial myself, we were born with a little touch of anxiety to start with. Like my patient we say, I'm tired of being part of historical events and I'm only 42. So bringing our psycho-oncologist, I had the pleasure of working with Dr. Christina Pozo-Catterman. She helps these patients with coping with the diagnosis, new ways of treating some of these mental health issues aside of medications. Medications are very helpful, but therapy has a very important role in their survivorship. So mental health has been described in breast cancer, colorectal, and lung cancer to have higher prevalence in younger patients. So higher prevalence of depression, higher prevalence of adjustment disorder, and anxiety. So working with psycho-oncology is key for survivorship of these patients because it goes by phases. At the beginning, everybody's all hands on deck, right? And eventually the layers of support peel off as the patient moves in their cancer journey. So psycho-oncology is very helpful. And another multidisciplinary care that we often forget for young onset is financial advisors and social work. These patients don't have lifetime savings. These patients often need to remain in their job to keep their insurance, and that affects their survivorship. How they are able to make 2 appointments, not to make it 2 appointments, worry about switching to Cobra insurance when they can. So financial advisors and social workers are essential for treating young patients because allows to apply for foundations, adjust things as needed, and know about resources that often as doctors we don't know. And in Massachusetts, I'm very fortunate to be in a state with Medicaid expansion. And there's a lot of things that I'm not familiar. So these are only 3 of the teens that are very important when we're creating for young onset. But I think the fourth teen is family members and caregivers. They are part of the cancer care team as much as the surgeons, as much as the radiation oncologists, because sometimes grandma needs to help with childcare. Sometimes grandma needs to help drive somebody. So they need to be included in conversations as well. And young onset cancer care is no longer the medical oncologist's job, it's everybody's job, including society as a whole.
I completely agree. And I hope we can come up with new and better ways to support caregivers in future years, because I think this is, as you say, a very critical part of our care team. Is there anything else you want to tell our audience today before we close, Dr. Florez?
I think something that I want to ask our audience is to look at patients with open eyes and remember that what we learn in medical school has changed, that the patient that we learn from our UCMLE step 1, 2, and 3 is no longer the full reality. Lung cancer is not older men with previous tobacco history anymore. Colorectal cancer is not older men. So come with open eyes, see the patient's needs, because unfortunately, this phenomenon will continue to grow and more younger patients will be diagnosed with cancer. So open eyes, remove some of the gender bias, remove some of our unconscious bias, and see these patients with higher needs instead of they can do it on their own. They actually need additional support.
Thank you so much, Dr. Florez. Today, we've talked to Dr. Narjust Florez about cancer survivorship issues in young adults. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on cancer survivorship. This is Dr. Kathryn Ruddy for the Medscape in Discussion Cancer Survivorship podcast.
Thanks for listening to Medscape's In Discussion Cancer Survivorship podcast series with our host, Dr. Kathryn J. Ruddy. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on cancer survivorship.